Coming back to the topic, this is about sucroferric oxyhydroxide. As we all know, there is this complex interplay in the calcium and phosphate metabolism, and I wouldn't go into the details of this, but as mentioned by our chairperson, that as our disease of the kidneys progress, there is a rise in the levels of phosphate. So hyperphosphatemia is, of course, a serious and a common consequence, and unfortunately is associated with the exacerbation of secondary hyperparathyroidism, increase in the risk of cardiovascular events, increase in the mortality in patients who are undergoing dialysis. And been seen that administration of phosphate binders would greatly reduce the risk of mortality. And as mentioned by Dr. Sabir, that as the disease of chronic kidney disease progresses, there is a steady increase in the levels of phosphate, and this again increases the risk of mortality as the disease progresses. This is also seen in patients who are on dialysis, that as your phosphate levels increase, your risk of mortality would increase. So in order to sort of reduce the phosphates, we need to have a phosphate binder, because reducing the phosphate in diet is not very easy, because you will have to then cut down on the protein intake, which can create problems. So the ideal phosphate binder would be one that would bind the phosphorus in the digestive tract, should be minimally absorbed, should not cause vascular and cardiac complications by itself, has a high and a specific affinity for phosphorus. It binds, it has a high binding capacity and is non-toxic, is well tolerated, and should reduce the mortality risk, and most importantly, should be easy to administer. So if you look at the history of phosphate binders, initially we had the aluminum binders in the 70s, then came the calcium binders in the 80s and 90s. In the 2000s, we had sevelamer and lanthanum, and now we have these iron-based phosphate binders. So the aluminum containing phosphate binders were very effective, very well tolerated, were associated with a low pill burden, and but unfortunately it was found that it was associated with encephalopathy, osteodystrophy, and microcytic anemia. So very many people now suggest that it's not really the aluminum that we were giving as far as a phosphate binder that was responsible for all this. It was perhaps the aluminum in the water that we are using for our dialysis patients that may have caused the problems. The calcium-containing phosphate binders are still very widely used, and there are concerns with the increased risk of hypercalcemia leading to vascular calcification. And these meta-analysis of the randomized controlled trials, which were published in 2013 and 2016, has shown that the increased risk of mortality is compared, there is using calcium-based phosphate binders as compared to non-calcium-based phosphate binders. Amongst the non-calcium-based phosphate binders, you have the magnesium-containing phosphate binders, but the problem with that is that it can cause hypermagnesemia. And as General Verma said, that the sevelamer or lanthanum are the two that we most commonly use. Sevelamer is the most commonly used, which can either be in the form of carbonate or chloride. But the problem with sevelamer is that very often we have to use a large number of pills to get the desired response, and then you have the gastrointestinal side effects with these drugs. Lanthanum, on the other hand, has this potential risk of accumulation because it's a heavy metal in the bone or in the central nervous system, and latest reports suggest that there could be some accumulation in gastrointestinal submucosa. And now we have these iron-based phosphate binders, ferric citrate and sucroferric oxyhydroxide. There are certain other phosphate binders, non-phosphate binders, which are under clinical investigation. One of them is nicotinamide, which would reduce the sodium phosphate co-transporter 2B in the small intestine, which will reduce the phosphate absorption. And the other one is tenapanomer, which is a small molecule inhibitor of sodium hydrogen exchange isoform, and this acts in the gut to reduce the sodium and the phosphate absorption. Now, ferric citrate, which is being used, it releases ferric iron after administration, and therefore can lead to increased levels of ferritin and TSAT. So if you are using ferric citrate, it's extremely important to monitor the iron parameters. And there's always this potential risk of iron overload. And a number of patients in many studies have been reported to have a ferritin in excess of 2000 nanograms per ml. So this is one side effect that has been seen with the misuse of ferric citrate. And maybe that is the reason it hasn't become too popular as yet. Now, sucroferric oxyhydroxide is a novel non-calcium iron-based phosphate binder, and it possesses better phosphate binding efficacies than other phosphate binders. Uh, it has about 33% polynuclear iron oxyhydroxide, 30% sucrose, 28% starch, and less than 10% water. It's a chewable tablet. It rapidly disintegrates into small particles upon contact with the saliva or water, and the iron content of a tablet is about 20%, and the iron uptake in experimental studies has been found to be very low. The dose that is recommended is about 3 tablets per day. That is 1 tablet administered 3 times daily with meals. And the maximum recommended dose is about 6 tablets per day. Now, where is the phase 1, phase 2, phase 3? If you look at those studies which have been done with this molecule, the phase 1 study, which was done in healthy subjects, had shown minimal risk of drug-to-drug interactions between these agents, sucroferric oxyhydroxide, and various other drugs which have frequently taken by patients of chronic kidney disease. The phase 2 study, which was an international open-label study in hemodialysis patients, which was comparing this agent with sevelamer carbonate, and they gave patients varying doses of sucroferric oxyhydroxide, very low doses of 250 milligram, and then they increased the dose to 1.5, 2, or 2.5 grams of iron per day. And sevelamer was given 4.8 grams per day. And they found that serum phosphorus was significantly reduced with all doses of sucroferric oxyhydroxide, including this lowest dose of 250 milligrams. However, the reduction of the phosphate was significantly more with higher doses of this agent. And if you use sucroferric oxyhydroxide in the doses of 2 or 2.5 grams, you found a better response as compared to sevelamer. Of course, the response of this agent was similar to sevelamer if used in the dose of 1 to 1.5 grams. So this is just to show you the same thing, that if you're using 2.5 or 2 grams of this agent, then you had a better response with reduction of phosphorus as compared to sevelamer. And if you're using 1 to 1.5 grams of this agent, you had a similar response as sevelamer, 4.8 grams. 250 milligrams per day, although it reduced the dose, but was not really significant reduction. The phase 3 trial, which is an international multi-center 2-stage randomized active control parallel study. And the patients were randomized to receive either the sucroferric oxyhydroxide of between 1 to 3 grams per day, which meant 2 to 6 tablets of this agent per day, or they were receiving sevelamer 3 to 18 tablets per day. And it essentially was done to demonstrate whether this agent is not inferior to sevelamer at 12 weeks, and then they had an extension study period up to 52 weeks. And they also wanted to demonstrate the superiority of the maintenance dose over lower dose. So when they looked at this, if you look at the red one is a sevelamer, and the blue one is the sucroferric oxyhydroxide, and you can see that the lines are almost identical, and really there's no difference. In fact, the sucroferric oxyhydroxide caused a change from the baseline much more than sevelamer. And this change was persistent throughout the 52 weeks of study that they did. It is almost a year study. If they looked at the number of pills, the pill burden, which is important because after all your patients have to take this on a day-to-day daily basis, they found that the number of pills that the patients took was far less in patients who took this new agent as compared to the cevilemer carbonate. Only 4 per week per day as compared to 10 of cevilemer. So the pill burden was greatly reduced when you were taking this agent. Again, there was this with ferric citrate. I told you that there was this accumulation of iron. So they looked at whether there was any evidence of iron accumulation, and they found that the levels of iron were same whether using sucroferric oxyhydroxide or using cevilemer. That there was no difference in the short term or in the long term about the iron accumulation. So there was no additional iron accumulation with the use of this agent. Regarding adverse events, they found mild transient diarrhea, discolored feces were more frequent with this agent. Constipation and nausea was more frequent with cevilemer carbonate. So the side effects were not really very significant except for some transient diarrhea. This agent was also tried in patients undergoing peritoneal dialysis, and they found that sucroferric oxyhydroxide was not inferior to cevilemer for reducing the phosphate levels by week 12, and the reductions were maintained over 52 weeks to the same extent. And again, they found that the patients required to take lesser number of pills as compared to cevilemer. Another publication which was a reanalysis or a post hoc analysis, they found something very interesting, that this showed that the reduction of serum phosphorus is much better in elderly individuals as compared to young adults. So therefore, they said that in younger patients, you need to closely monitor their serum phosphorus. The exact reasons for this were not very clear. However, it may be related to dietary indiscretions, perhaps. In the real world experience, there have been some publications which have shown that that whatever has been claimed by the manufacturers, they found that there was a significant reduction in the serum phosphorus level, and the proportion of patients with a serum phosphorus less than 5.5 increased significantly, almost from 15% to 30%. There's 95% increase by the 6 months of follow-up. So the effectiveness of this agent was evident at 3 as well as 6 months of follow-up. And again, in this study, they showed when they compared the number of pills, which is an important thing, patients were taking with various types of phosphate binders as compared to this agent, they found the number of pills was much less when they were taking the new agent. So in summary, sucroferric oxyhydroxide displays a high phosphate binding capacity, and most importantly, it can reduce phosphorus with a relatively low pill burden. It has a favorable side effect. It's formulated as an easy to chew tablet with convenient dosing. And there is minimal iron absorption with no evidence of iron accumulation over 52 weeks. And they found to be more effective in maintaining controlled serum phosphorus levels and lower pill burden, leading to better treatment adherence than cevilemer carbonate. So this sucroferric oxyhydroxide is a new kid on the block. It's a promising addition to our therapeutic armamentarium for the treatment of hyperphosphatemia. Efficacious treatment of high phosphate binding capacity and with the low pill burden, convenient administration, and better tolerability. And again, the drawbacks seen with previously used phosphate binders do not exist. That is, there's no increase of the calcium levels, no iron accumulation. So this is one agent, perhaps, that could be useful and may revolutionize the treatment of hyperphosphatemia. Thank you very much for your attention.